Welcome to the Health Links podcast, where we bring you conversations that empower healthier living. Welcome to the Health Links podcast, where we engage in conversations that empower healthier living. I'm your host, DJ Thatcher. May is Speech and Hearing Awareness Month, and this episode is all devoted to the hearing aspect of that. We're joined by Rob Shilot, who is the president of Beltone Coastal and is also a hearing care practitioner. Rob, welcome to the Health Links podcast.
Yeah, thank you for having me.
So we have awareness months all the time. Tell us, what's the prevalence of hearing loss or hearing issues that you're seeing in your profession?
Yeah, absolutely. So most of the patients that we see are developing hearing loss just as we age. It's a natural part of getting older. It's something that...
Keep hearing that all the time. You know, everything is...
It's true. And of course, we do work with younger patients who might have, congenital or hearing loss that they were born with and other factors. But most all of us, sooner or later, are going to experience some hearing loss. And generally what we'll see is high frequency hearing loss, which by definition, they have trouble hearing sounds that are higher pitch. But really what becomes difficult is speech. And so that's, there is that connection between speech and hearing.
Sure.
So a lot of the patients we'll see, in a quiet room like this, if you were talking one-on-one, they wouldn't have a lot of difficulty hearing. It's more difficulty understanding sometimes, particularly if they're not looking at the person that they're talking to, if there's background noise of, some version. A restaurant is always a good example, and they'll hear people, but maybe it's not clear what's being said, or they're having trouble understanding clearly what's being said. They'll also notice trouble with like dialogue on the television, those type of things. So those are some of the more common.
I've seen that with a relative, yeah.
Sure. I think we all know someone who has hearing loss. And it's one of those things that, like certain medical things that we might want to kick the can down the road or that we delay a little bit. I think because of its relation to aging, there's sort of that stigma where people, they don't want to admit that they have a problem.
Right.
And generally it's a family member or a loved one who's encouraging them to, get help.
Sure.
So we want to make sure everyone's aware of, number one, how easy the process is to get a hearing test and how important it is to catch it early, And that's obviously common in all things medical. The sooner you catch something, the better the treatment outcomes. And, an ounce of prevention's worth a pound of cure. Is that the...
Yes. No, you got it. Well, we'll get into all of that. I know as I get older, my checkoff list keeps getting bigger and bigger, so... Well, it's interesting. The older I get, the longer my check sheet is of things I need to check on. I think the hearing is okay right now, but what's actually happening? I understand with heart disease, our arteries wear out, they get hardened and so forth. What's actually happening within the ear, though, Rob, that creates hearing loss as we get older?
Yeah, that's a great question. So basically, when we think of our hearing, there's the ear canal, the eardrum. It's really in the inner ear within the cochlea.
Okay.
And that's what houses the nerves, the cilia. They're like little hairs that vibrate to send signals to the brain. So there's nerves responsible for low frequency, mid frequency, high frequency. The nerves in the low frequencies, if you picture those hairs, they're moving much slower.
Okay, makes sense.
The mid frequencies move a little faster. They work harder. The high frequencies move a lot faster than what I could demonstrate.
Sure.
And so for that reason, they're going to wear out quicker. And it actually ties back to speech, because when we think of speech or any hearing in general, we kind of think more in terms of volume, louder.
Louder's better.
Right. and so loud and clear aren't precisely the same thing.
Sure.
So with clarity, it's much more tied to the pitch or frequency.
Okay.
And I'll use this word example with my patients to kind of illustrate that point. And I always use the word this. So it's a one-syllable word that we use every day.
Sure.
In that one syllable, the ear picks up three different parts of speech. So there's the sound of TH, I, S. But if we don't hear all three sounds, we might have heard their voice, but it wasn't clear what someone said. So just for example, the TH sound is really very high frequency, very soft sound.
Okay.
You could say the same with S. It's a higher pitch, but soft. The I sound is more vocal. In fact, all the vowels, but the I is the louder, easier part for patients to hear. So if someone doesn't hear the TH and they don't hear the S, obviously what they heard was it.
Yeah.
So in some, of course, that's an example, but in some version, words get clipped off and then run together. And so almost to them, it's like someone's mumbling. And that would be the thing someone would notice perhaps that might prompt them to get their hearing tested. It is recommended at 55 to start, getting that baseline test, but often patients wait until they do notice a little difference.
Well, that's everything, right? Yeah. Wait till it's too late, or at least well into the process.
Sure.
So besides besides aging, we know that high frequency sounds or very loud sounds are harmful.
Yes.
Not having hearing protection. What are some of the more common things you see that people are doing that they could stop right now and improve their hearing?
Yeah, no, that's another really common thing we'll see, particularly with the generation of patients that we work mostly with, is, certainly before OSHA and requirements of hearing protection, a lot of noise that's going to be related, mechanical noise oftentimes, so manufacturing, farming, anytime you're going to be around loud equipment for extended periods of time. So anything over 85 decibels can become damaging over a long enough period of time.
What's 85 roughly? What's an example like 85?
A lawnmower would probably be, that would be louder than that, but it's actually not as loud as you might think. I mean, as far as what could be damaging for maybe a couple hours.
Okay.
In a short time, anything over 100 decibels, that think of like a jet air, the turbines in a jet. That's quite loud, but that can be damaging, within a few minutes, even less. So loud concerts, but usually it's shooting. A lot of hobbyists and enjoy shooting and don't always wear hearing protection. So there are a lot of examples of things we'll run into. Even something as simple like as noise in a vehicle. So when you're a truck driver and you have the window down a lot, that ear is going to be getting some of that wind noise. The engine noise is going to have more exposure on that side. So
you can see it. You can see hearing loss on one side versus the other, maybe.
We'll notice those patterns, and you can never definitively say this is what caused a hearing loss. We can determine there's a loss. We can determine if it's nerve damage or what we call conductive loss, something in the middle ear. But you can look at like someone who's a truck driver and you see that left ear is a little worse. A police officer and the Weaver stance and how they might hold a pistol and how they would sight that one ear might be more exposed. So there's times where, I've had a police officer and they were left-handed. I've asked them, are you left-handed? Yeah, how'd you know that? And it's because in that particular case, their right ear.
You're seeing this on the hearing test.
Right.
Okay, we'll talk more about that in a moment too. Yeah, this is a huge lifestyle issue. And I imagine people are coming to you because they've reach their limit, either the patient because they can't hear, or I imagine maybe a family member or someone else because they're getting frustrated because they're repeating themselves. Is that a fair statement? Or
yeah, absolutely. And I think males are particularly, we're not as quick to want to go and take care of those types of things. Not to generalize too much, but often there are wives bringing their husbands in and saying they're saying they're fine. I'm turning up the TV, I'm just not paying attention. Selective hearing is the big joke that we get all the time. And with females are a little seemingly more preventative and they want to take care of that. That's, just a common thing that we'll see, but it's very often a family member because it happens so gradually. So really, to be fair, we don't wake up one day and we've lost 20% of our hearing. It's changed at such a gradual and over such a long period of time. We're conditioning to it as that change occurs. And so we don't really notice that the television has creeped up or that we're not hearing when our, spouse or loved one is in the other room talking, where we might used to be able to understand clearly what they said, things like that.
I see. Well, tell us about Beltone Coastal. So
Sure.
Large organization, you're the president of that, and you have a large presence in the Low Country throughout the Carolinas, correct?
Yes, yeah. So we've got 28 locations throughout South Carolina, North Carolina. We started down here. We took over from the previous owner who was in the Low Country, was with Beltone for a long time, 40 years, and
Wow.
and he retired. His son, Michael, still works with us. But they ran a good, family business, and we were able to carry on, forward and start to grow our reach into certain areas, Beaufort and Hilton Head, towards Myrtle Beach, Murrells Inlet, Pawleys Island, and then a couple years later, we expanded into the Columbia area.
Okay.
So we've got some offices up there. Within the last couple years, we've also expanded into like Raleigh, the greater Raleigh market,
Nice.
and on the eastern part of North Carolina. So Greenville, Washington, some of the coastal parts of North Carolina as well. So yeah, it's been great. I really have a passion for helping people hear better, and working with Beltone, it's been great how we can improve accessibility, particularly in some of the rural areas where there's not a lot of options for where you can treat your hearing loss.
Sure.
But then even in markets and areas like Charleston, we offer a free hearing evaluation, and that lowers the barrier for someone who might already want to put something like this off.
Right.
And so it invites them to come in and at least get that baseline testing. So
Okay.
yeah, but
So-
I'd love to tell you more about Beltone.
Yeah. Well, interesting. So each location is freestanding, has a hearing care practitioner there, and obviously with Beltone, you also manufacture. Your sister company, I guess, manufactures the devices. But is this the type of place people should start going at a certain age just to get a hearing test done, whether they need a device or not, or what?
Yeah, that's a really good question, because it remember we talked about how gradually it changes.
Right,
And so
right.
oftentimes you might not notice if you have, especially a mild hearing loss. And so it is a good idea to, 55 or older, even if you're waiting till 65 to start, getting that baseline test. But we're not necessarily going to have someone who has no hearing loss test every year. If they,
Right.
we say, okay, let's, check back in a couple years and we'll keep an eye on this. But if you notice anything, obviously come in sooner. But yeah, generally starting at around that age is recommended.
Okay. Does that lower if you're at a high risk type of profession where there is a lot of noise? I don't know if you have a special recommendation for that.
Yeah. I think most of those occupations require some annual. If there's a great deal.
I've one of those. Yeah.
Yeah.
You had to do the hand thing. They didn't really tell you how you do though. It's just, you pass.
Yeah, and a lot of times because they're doing all the employees, right? They're
Right.
doing it's kind of in and out. It's a very quick, sometimes even a portable booth situation where they come on location. So we do have, Department of Labor and certain different people who will come in and to get that baseline testing. And, we offer that as well.
Okay.
So if you're just getting a baseline test and you're not having any issues, it's maybe 15 minutes to do
Right.
the entire test. So it's not a long drawn out process. If someone does present with hearing loss, we do obviously a much more comprehensive test to go through to figure out candidacy, see if they're going to really improve from a recommendation.
Sure. Now you're a hearing care practitioner. What's that education like? We have audiologists, we have ear, nose, and throat physicians and things like that. So what are some of the differences there, and when might you need to see one versus another?
Yeah, absolutely. So as a hearing care practitioner, we basically get licensed through the Department of Health with South Carolina. So there is national licensing through the International Hearing Society. So generally you're going to have to apprentice for a year, maybe 2 years with someone who's already established, or perhaps an audiologist. And then you're going to take your national licensing test, and that's something required throughout the U.S. Then each state has its own standards where you'll take, your local board testing, where you'll have to demonstrate your knowledge in audiometry and taking ear impressions. So it's a pretty comprehensive test to make sure that the professional is really able to recognize certain diseases of the ear, because in the differences of an audiologist, it would be certain diseases balance. We will recognize right away if this is something where we need a referral to an audiologist. We're focused primarily on treating hearing loss, generally sensory neural hearing loss, meaning nerve damage, the more natural progressive loss.
Sure.
If someone presents with an issue that might tell us that, okay, there could be a middle ear concern here, we're going to refer them to an otolaryngologist or ENT.
You're right. You're right. It's a mouthful. Yeah.
Right. It sure is. So we're going to refer them, and if everything checks out, or if they recommend a procedural approach, they're going to take that from there. If they feel like, sometimes due to age or other underlying conditions, they may not want to recommend a procedural approach. Right. So oftentimes the patient does not want to have surgery if this is something that could be treated with prescriptive amplification.
Okay.
So they will then refer them back, and we'll complete the other more comprehensive part of the test, this what we call speech testing and speech discrimination.
Interesting. So what's that like? If I'm having some hearing loss, or more than likely my spouse is having me, go in because I'm not hearing, whatever.
Yeah.
That's a chronic problem. But so what is the testing like? I mean, we're familiar with some of the basic tests, and then you mentioned the speech as well. So what can someone anticipate?
Yeah. So just to start at the beginning, when a patient comes in, we'll do a case history.
Sure.
And we're going to get some examples, and generally recommend that their spouse join them if at all possible, because sometimes we're too close to the problem. But again, getting back to that gradual change, our loved ones tend to notice it first. So we're going to gather some examples and get some anecdotes as to, different situations that have come up that they've had trouble. And then we'll eventually go through just the basics of how to read an audiogram before we even start and do the pure tone testing, which is the testing.
That's what that's called. Okay.
Yeah. We're going to show them what the results could look like. And so when we put that chart up, they really understand right away what they're looking at.
I see.
Here's a normal threshold. Here's the speech window where sounds and speech occur. Here's a common high frequency loss that, we see every day. After that, we're going to ask some medical questions too. We're going to make sure that this wasn't a sudden onset loss. And just as, a kind of a public notice, anyone who ever might experience a sudden change in their hearing loss, that's something to get taken care of right away. There are situations where if you wait too long, the treatment changes, and that's something you would see an ENT for if you wake up one day and you're noticing a considerable change in your hearing. But you need to convey that urgency on the phone, because oftentimes ENTs will have 3-4 months booked out.
Sure.
And not to get too far on this aside, but it is an important thing. If they get in quick enough and they're able to treat that, oftentimes some of that hearing can come back. So we want to make sure there wasn't a sudden onset loss. We want to make sure they're not having any pain in their ears.
Okay.
And then we're going to check to see, and with the otoscope to see, is there any wax, blockage?
Something simple.
Right. Are we looking at a healthy eardrum here? Is there possibly a puncture in the eardrum or something? So we're going to eliminate all those concerns. If everything is okay, we'll place in the inserts. So we use a digital audiometer.
Okay.
And rather than the hand gesture, they'll just press a button whenever they hear the tone and measure their thresholds across different frequencies. So where do they begin to hear? It's not necessarily where we hear well. It's the lowest we can play that sound and still get a response.
Okay.
So from there, we'll explain the results and kind of show them that visual of where they're hearing relative to normal. And what I think more importantly is relative to sounds in speech. We talked about the TH and S sounds, but there are a number of consonant sounds in the high frequencies that we might start missing. And then if, we do see there's hearing loss, the speech testing, first we want to get a baseline measurement. Either if they have, if it's with their natural hearing, in other words, haven't pursued treatment before, we'll measure to see what percentage of speech are you picking up currently. If they have hearing aids, we'll want to measure with their current treatment.
Sure.
And we'll want to make sure that device has already been optimized for an updated audiogram. So we'll see patients all the time who may have pursued treatment somewhere else and they weren't tested again or they haven't been tested since they originally got their hearing aids. And so, even some mild changes could really change the performance of that device. So we'll update that, maybe schedule them back to do the speech testing later.
Gotcha.
That gives us to give like a before and after. So what are you picking up currently? And then compare that to what we can get you to. So we'll do some what we call most comfortable level, uncomfortable level measurements. I always relate this to like when you get glasses and they put the different
Right. Yeah.
tell them what's more clear. So we'll get a sense of what sounds good to you, what's a comfortable volume, because we've talked a lot about frequency up to that point. And then simulating hearing aids, we'll test again to see how much improvement we can show.
Okay.
And because background noise is often a situation that's difficult, sometimes we'll do speech and noise testing to basically see how well they're going to perform in those type of environments. So it's pretty comprehensive. And of course, through all that, we're giving explanations. You know, if we see something that might concern us that if left untreated, this could have some cognitive impact, you know, we're going to counsel through that as well. So,
I'd like to hear about some of the most recent devices you have. And I was thinking, you mentioned a little bit ago about hygiene and just looking in the ear. What are some do's and don'ts that we should have just to keep our ear canal clean and so forth? Now, you shouldn't be shoving Q-tips in there or anything, but what are some things that anyone in the audience could benefit?
So there's a lot of bad habits out there.
Yeah.
And one of the things of a certain generation is like a bobby pin. And people want to actually clean their ear with
That's absolutely.
And I mean, I'm sure they're not, you know, touching their eardrum, but it's just, I mean, that can be dangerous. You know, when you can't see into the ear canal, when we think we're putting even a Q-tip, which is of course designed, you know, for ear hygiene, but what often is happening is you're impacting that wax. You're thinking that you're cleaning it out, but because you can't really see what you're doing, you're just pushing that wax further in the ear. So often, as one of the things as we age too, sometimes, you know, the ear canal is just skin all the way up to the eardrum, the tympanic membrane. And as that skin gets drier, that wet wax will, the skin will draw that moisture out and it will stick to the ear canal. So really one of the best things you can do is have someone take a look in your ear. Of course, that's something we do all the time. Oftentimes patients are saying that their primary care, you could ask your primary care to take a look. If you don't mention it, it may not be something they do, maybe for a regular routine physical.
Sure.
But just make sure every so often you're having someone look in there. And I would avoid, you know, using Q-tips and those things. It seems counterintuitive, but for the most part, naturally, our ear will expel the wax. There are variables and things that can change over time that makes it more likely to stay in there. But just about any primary care, or a lot of times even the walk-in clinics, certainly an ENT's office, can do a professional wax or cerumen removal. And that is something that Medicare or your insurance would likely pay for. So
interesting. Okay.
And it's a very simple process.
I'm curious. Okay, that's good.
Yeah, good question.
All right, let's say I have now true hearing loss. I did not want one of those great big things in my ear. It signals to the world I'm deaf, or what people think. So what's the latest in technology that we have that...
Yeah, absolutely. I mean, technology, you know, I've been doing this 12 years and how much I've seen it change even in that time. At the time when I started, you know, it was digital hearing aids, but one of the big changes is now our ability to adjust at every single frequency and how someone's hearing in noise. You know, anyone who's listening who's ever worn hearing aids or who's suffered hearing loss knows that they really struggle in a restaurant. And for a long time, even with hearing aids, because they're targeting frequencies where speech is received, well, in a restaurant, the noise is speech, right? And so it can overwhelm and just make it difficult to hear the person who you're looking at, who you're trying to hear. And actually, AI has been really a leap forward.
I was going to ask you about
that. I mean, obviously, that's the big buzzword, right? And it's changing a lot of technologies, but it's allowing the hearing aid to discriminate speech and noise much more, you know, effectively, and actually locate who it is that you're looking at to target that voice and bring it up and recognize other noise to bring that down. So that's on the performance aspect of things.
Okay.
You know, everyone cares about having a discrete option, right? And particularly for men, you know, where women's hair might cover, you know, a receiver in the ear type device, which is probably the most common hearing aid that most people would see has the small wire that comes down with a little speaker. And they have gotten to be very small as far as what sits behind the ear. That's definitely our most popular option for comfort, rechargeability, getting, you know, Bluetooth connectivity and some of these great features. But, you know, if someone is really really conscious of having something totally invisible. We do offer custom in the canal, or what's called an invisible in the canal device. And so we'll take an impression of the ear canal and have a hearing aid that's fabricated precisely for their ear. And that way, when they push it past that bend in the canal, even if you're looking in the ear, you really don't see it.
Wow.
There's also some other technologies now that's what we refer to as a custom.
Okay.
But there are technologies also that are instant fit, where we can put it down and it slides in the ear and is very discreet as well.
So, Rob, we've just done a whole series of podcasts related to Alzheimer's, dementia, Parkinson's, and so forth. And I believe there is a correlation there with hearing loss and those diseases. Is that correct?
Yeah, absolutely. So this is something that we've long known, and even before some of these studies came out, suspected in our industry, because of how the brain works and how hearing really works. And to understand it, first we have to think about the fact we don't just hear with our ears.
Right.
The ear's job is to take in and process.
It's really a brain issue, right?
Exactly. So, sound travels down the ear canal and it goes through this series of conversions, from an acoustic energy to mechanical at the transfer to the eardrum, and eventually hydraulic, electrical, chemical signal to the brain. I mean, it's a fascinating, complex system, but nowhere in there would you say that it understood anything, right? So the ear without the brain would be effectively useless. Something we discuss with our patients, auditory deprivation, is where the brain can actually lose the ability to interpret certain parts of speech, for example. And when patients wait too long to treat their hearing loss, what happens, we can get the ear to hear that sound. As long as those nerves are responsive, we can get it to send that signal. But if the brain doesn't respond to them, it's the same as not hearing it. It's like the message was sent, but it wasn't received. So, that's kind of the bridge that connects that. But, Johns Hopkins did a study, someone with mild hearing loss untreated is twice as likely to develop dementia. Someone with, and that's mild,
yes,
right? Moderate is 3 times, severe is 5 times more likely. So there's a strong correlation. The Lancet Commission did a study, and they found hearing loss is the #1 modifiable risk factor. So, we can't change our genetics, but as far as even like diet and exercise, keeping that part of the brain stimulated, because also, of course, hearing loss is someone who's experiencing it might start to withdraw socially, start to avoid certain situations. And so, that it's got that snowball effect. But it's something that we see a big increase
Shocking.
for our patients when they take care of it, of how much more active that they become as a result. So,
Rob, you mentioned earlier you provide a free consultation for people. I'm sure those who have suspected hearing loss will take advantage of that. What if someone already has a hearing device and they're just wondering if it's really the best or the most up-to-date? Is that something you evaluate as well?
I really appreciate that question, because we actually have a lot of patients who may have pursued treatment elsewhere, but they're noticing, like we talked about, trouble in noise. That's a big one. Or they're just not hearing, their spouse is noticing that they're not hearing them as well. Maybe it's a performance issue. They've noticed some change, but they just want to have someone else take a look at it. So we offer the free hearing test for them the same as anyone, but we can also update their device at no charge.
Oh, interesting.
Yeah, so we have the software to work with all the manufacturers, and if we update their hearing test and there's been some change, updating each of the frequencies that are adjustable in their hearing aids could really improve their performance. So
wow.
The thing that most people are going to notice is that they can hear, but it's not as clear as it used to be, or they're not understanding people as well as maybe they used to. So we'll do an optimization of their hearing aids at no charge, and that's something that we do every day.
Terrific.
Yeah.
One of the things, and as we wrap up here, one of the things people often ask about is, hey, what's the cost, or if not the actual cost, hey, is it covered by insurance and Medicare and so forth? Yeah. What services are covered?
Yeah. So obviously the test is free. We don't bill Medicare or even a supplement or private insurance for that. If someone is a good candidate for treatment, because Medicare doesn't currently cover hearing aids, the supplements don't have to. But what we find is a lot of them do have managed care coverage. Sometimes they're not even aware of it, the patient themselves.
Right.
So we'll do a benefit analysis when they come in. The patient care coordinator or the receptionist up front is going to gather some information. And while we're diagnosing or actually, testing their hearing, they're going to check to see what type of benefits that are available to them. A lot of our patients have Medicare Advantage plans, which do have benefits. We're in network with all of the, major insurance companies. So we're able to maximize, their coverage, minimize any out-of-pocket expense. And sometimes patients are really surprised by how affordable it was. I mean, medical equipment, hearing aids can be costly, but we have, depending on their lifestyle, depending on their budget, options that are very affordable. And we also, if there isn't an out-of-pocket, offer a monthly payment plan.
Oh, nice. Okay.
So that is flexible.
Got you covered.
Yeah, particularly patients on a fixed income, which is pretty common in retirement, obviously. So yeah, we would go through those options and make sure we find the treatment option that is really comfortable for them and is going to do a good job.
Terrific. Well, this has been a great overview. And again, May is Speech and Hearing Awareness Month, but don't wait until May. We'll provide the contact information here for Beltone Coastal. And Rob Shilot, president of Beltone Coastal, thank you so much for joining us here.
Thanks so much for having me. I really enjoyed this. Thank you.
And thank you for joining, and we look forward to seeing you in our next episode where we'll engage in another conversation to empower healthier living. I'm DJ Thatcher. Thanks again for joining.